Let's move on to the last session before tea break. That's Rickets and Liver Disease. Presenter Dr. Abhamoni Baro, moderator Dr. S.K. and our panelists Dr. Archana Kher, Dr. Seema Alam and Dr. Girish Gupte, please.
We can start with the presentation.
Good afternoon, everyone. I present a case of a 13-year-old boy who came to us with a complaint of pain in knee joints since 4 years, difficulty in walking and standing since 4 years, progressive deformity of the right knee since 2 years, and swelling of the knee and ankle since last 1 year. There was history of intake of mega doses of vitamin D and calcium in the last 6 months. The child was once treated as oligoarticular juvenile onset idiopathic arthritis in 2011 with 2 months of steroids. However, no history of any morning stiffness, no fever, polyuria, trauma, or chronic diarrhea, no history of jaundice, weight loss, chronic drug intake, or repeated fracture. The prior growth and development was normal. The birth history and the family history was not contributory.
Just hold on now. So, Dr. Archana, I would like to have your inputs. I think this patient is this line of resistant rickets and also the management of juvenile arthritis adopted by whosoever is all right in your opinion?
Some other history like any past history of rheumatic fever, because 13-year-old we would like to know if there was rheumatic fever, whether the spine was involved or not, and any other major illness in the past.
No history of any other major illness in the past.
Now, this is actually treated as juvenile arthritis, not as rheumatic fever.
No, there's no mention of any cardiac complaints. 13-year-old who has joint pains, we would like to know if it is secondary to rheumatic fever.
And there are two components here. One is the deformity. Another what they are saying arthritis. There are two components in this patient, which is a little bit confusing.
Yeah, only deformity will not go in favor of arthritis, secondary inflammatory arthritis. Like.
Right. Okay.
Otherwise, from history, we cannot make out much.
So far, we don't have any clue, as the title says, rickets and the liver disease.
No.
We don't have a clue so far that this is related to the liver disease. So let us see what's further on examination in this patient.
On examination, the child weight was less than 3rd centile, but the height was in the 10th centile. Vitals were stable. The child had pallor with bilateral wrist widening and normal dentation. No icterus, no lymph node, no signs of bleeding, no sternal tenderness. However, the child had dull apathetic faces, and on inquiry, there was a declining scholastic performance. Per-abdominally, the child had splenomegaly of 3 cm with no hepatomegaly or ascites. No stigmata of liver cell failure was present. On CNS examination, there was wasting of the right quadricep muscle with a power of the lower limbs being 4/5, and the gait was a wide base gait. On local examination, the child had a genovalgum on the right side with a genovarus on the left with tenderness locally, and other systems were within normal limits.
No, hold on. Now, can we have some inputs from the audience? Can you have, is there any clue from this kind of presentation so far that there is involvement of the liver in this patient?
Yes.
Splenomegaly.
No, pallor would not go. Pallor can occur as a result of anything. That is not specific to the liver. Pardon? One is splenomegaly, she said. What else? Declining?
Scholastic performance.
Yes, very important. So these are the two clues. Dr. Seema, do you agree with that?
I
These
do
two
agree
points.
with this declining scholastic performance and with the splenomegaly of 3 centimeters, despite not having, stigmata of liver failure present. I would still think strongly of Wilson's disease here. Then go further on, we will not, I would keep it as a liver involvement.
We are not going to Wilson's at the moment. The point is, how would you, as a clinician, evaluate this scholastic deterioration in the performance? What particular points you would like to ask from the family or from the child?
The family history, of course, we'd like to know as to how is there any similar family history in the family, and of course, keeping in view this declining scholastic performance, I would also keep a record of the high handwriting as well as keep it serially, and take a detailed history from the parents.
All right. Anybody else? Any other point that you would like to take?
Drooling
School
also
performance is
there
deteriorating this child. So one is the handwriting, what she said.
Sorry, can I make a point that defining scholastic performance is always difficult in
Very
children,
difficult.
because there are so many other factors which may be really contributing to that we have to be really carefully analyze that, and not
Right.
take one viewpoint on it and tie two things together.
In a 13-year-old child, Dr. Gupte, would it be difficult?
Yes, it will be difficult in the 13-year-old child, in an adolescent especially, because there are so many things happening in their life at that point of time.
Dull epithetic facies and dull epithetic facies and the splenomegaly should help us that this is not just simple some other thing.
No, splenomegaly can be as a result of any other systemic disease.
Yeah, but then all of them together.
It might, because they have already given us a title. So that makes us to go in that direction. There should not have been a title. Just rickets and evaluation of the speech.
Still we should think of.
Anyway, that's important.
Speech is not mentioned.
So you would all agree with that. There is splenomegaly, there is deterioration in school performance, although it is difficult to assess in the Britain. But in India, it might be a little easy, and because there are many compounding factors, I agree fully with you. Not that, right? Okay, fine.
In a wide base.
Can we go further?
This was the picture of this child showing a genuvalgum on the right side and a genuvarum on the left side. So what are the differentials at this point?
No, what other features were
Go
there?
back.
No, just go back to that picture.
Yeah.
You just say, what any other features of rickets were there in this patient? One is the widening, you said.
Yes, sir.
Widening of the wrists. Anything else? Okay. Anybody?
Bleeding of ribs.
There is rachitic rosary. Okay, fine. So there is rachitic rosary. They are identifying widening of the wrists, and the genuvalgum is there. Right. And now you tell us differentials. We can have an evaluation rather than a differentiation here. Differential diagnosis. So you have a child who has got vitamin D resistant rickets, has got splenomegaly, has deterioration plus minus in the school performance, and non-response to steroid therapy, and therefore what would be our differential diagnosis?
This is second.
Dr. Archana.
It is resistant rickets. So there is some pathology going on which is damaging the renal tubules. This
Yes.
cannot be nutritional rickets at this age. There is wasting, the weight is also affected. So there is some affection of the renal tubules and a underlying major organ problem which has led to the weight loss, and maybe one clue, wasting of muscles, could indicate that there is a protein deficiency. In chronic liver disease, there is bound to be a protein deficiency.
Now, in this patient, the nutritional history suggests that the intake is very good, comes from a good family, let us say, though the nutritional component is not there, that would have been otherwise also corrected by simple vitamin D therapy. But here large doses have been given, yet the corrections have not taken place. And under those situations, one, you said the renal tubular acidosis has
Yeah.
to be thought of.
Yeah.
Anything else?
So there is the renal tubules being involved in relation to liver disease are only 5 or 6 conditions. This particular child.
Let us forget about the liver disease. We say only there is a case of resistant rickets not responding to your vitamin D therapy, and patient continues to have the rickets. One is, you said the renal tubular acidosis could be one. What any other possibilities there? Pardon?
But they will have jaundice.
No, at this age.
Chronic
At 13
tyrosinemia.
years.
But age is somewhat
It's too
little
long.
bit odd.
It's too long.
Too
Dr.
older
Ambedkar,
child.
Sir.
I think the most important point is this child has started the illness much later in life
Yes.
because the height is so good. So you need to pick up a metabolic disorder which starts late in the childhood.
Right.
And to that extent, I think we start thinking which is the one that starts later in life. So this is not an RTA or one of those which come with a failure to thrive early in life. That's where we know that this child must have started lately, maybe after 5 years. Now we put that on then we get a liver.
Right, absolutely. Anybody, anything crosses the mind? Dr. Gupte?
No, can I just mention that I find it means, like, I'm from Britain, like you've said, but I find it surprising that this child
With Indian
not,
heart.
with a very Indian heart, that this child does not have any jaundice ever, and yet has had such significant rickets. That's a little bit, of a worry
Correct.
for me.
Yes.
It's a little bit of a worry. I know that the heading is rickets and liver disease.
Yes, yes, yes.
But that's a worry for me that this child has
Right.
never had jaundice, and yet has got such significant rickets.
Can you just show us the investigations? Somebody must have thought and did a preliminary. Dr. Podar? Yes.
So, Girish, that boils down to the fact that this child has renal rickets. Is renal ricket. Main problem is the renal tubule, which is causing this resistant ricket. We are not telling the cause of the renal tubular acidosis. That is probably liver, but here is primarily the renal problem which has given rise to this resistant ricket, if we believe the story, whatever has been said.
On investigating the child had pancytopenia with a low HP, low total count and low platelet counts. The calcium was 8.4 but a normal total ionic calcium. Phosphorus was low of 2 mg per deciliter. Alkaline phosphatase was very high out with 1571. We tested the liver function test and all the liver function parameters were within normal limits. The renal function test was normal and the electrolytes were normal with chloride being on the borderline. 25 OH vitamin D was tested which was 68.6 and the PTH parathyroid hormone.
What is the normal for 25 hydroxy vitamin D levels? Is it normal or abnormal?
So it is normal.
It is normal, so okay.
20.
And PTH is? Yes.
Parathyroid hormone, it's low, that is 7.36 picogram per ml.
Right, okay. And then what do you make from this? Anybody can tell us what are you making from these investigations? One is that the hemoglobin is low, TLC is low, platelet count is also low. What does it suggest? Pardon? Hypersplenism. So there is pancytopenia and this might be hypersplenism in view of the fact that there is splenomegaly in this patient. That is one. And second thing is now, what is your comment on calcium phosphorus and alkaline phosphatase? Three things are there. Calcium is?
8.4.
What is that? That
This
is
is a low
normal?
calcium, low total calcium, but the ionic calcium is normal with 1.1.
And phosphorus?
Phosphorus is low,
Low. And alkaline phosphatase?
is high.
So you have got lower calcium, you have got low phosphorus, and you have got high alkaline phosphatase. Anybody?
Hypophosphatemia.
Hypophosphatemia,
Okay. And from the liver enzymes, SGOT, IGPT, normal, bilirubin is normal, INR prothrombin time is normal, protein albumin is normal, blood urea nitrogen is also normal, isn't it?
yes sir,
And creatinine also, how much is the creatinine?
0.4.
Okay, that's normal. So what do we make from this? And PTH is low. That is parathyroid hormone.
Yes sir.
Right. Anybody can make? Not easy. Not easy. There is some confusing picture. So we have definite evidence of hypersplenism. We have phosphorus which is low. We have got high alkaline phosphatase. And liver function tests by and large are normal. There is nothing abnormal in that so far. Can we go to the next slide? Let us see.
We worked up for the refractory rickets and ABG was done, which was suggestive of a pH of 7.36. Bicarbonate was 15.5.
This is venous. This
Venous,
is not
sorry.
arterial.
Venous blood pH. So the venous blood pH was 7.36 with a bicarb of 15.5 and anion gap was 13. The urinary pH was 7.5 with a specific gravity of 1030. There was no protein, sugar or calcium in the urine. The urine calcium by creat was initially high, 0.53, but we repeated the 24-hour urinary calcium found to be normal. The total reabsorption of phosphorus was 98%, which was normal.
Getting it to
So what do you make? This is a venous sample. So normally in a case of rickets where you may be suspecting a kidney disease, you might do an arterial lesion, you might do an ABG rather than a venous sample.
what was the first?
So what does this show now? Venous, can we make, Dr. Podar, can we make anything from this?
No.
From the venous sample? Dr. Girish, sir?
Why not?
Mild, yeah.
But I think, clearly this child has got compensated acidosis. Yeah.
Just mild.
Mild, very mild, I agree. And anion gap
Bicarb is also low.
low, yeah.
There is mild acidosis, bicarb is low, and urine pH is 7.5.
Yes, sir.
It's again not acidotic.
It is not acidic urine.
So this is not RTA.
So it is an alkaline urine.
Yes.
Yeah.
Proteins are negative, urine albumin is okay, and urine calcium. What is the normal level?
Urine calcium,
24-hour urine calcium is low or it's normal here?
it is normal, sir.
It is normal. So we have normal
So no
urinary calcium.
calciuria.
Right. So what is the interpretation from this? Your own interpretation.
Sugar was negative.
So there was some amount of renal tubular acidosis in this child, but we could rule out Fanconi's in this or a proximal RTA because no proteinuria, no sugars, no calciuria,
No
and the
calcium.
phosphorus was also reabsorption was normal.
Right.
It's
And
not Fanconi.
go to the next investigation.
USG abdomen with portal Doppler was done, which was suggestive of liver parenchymal disease with splenomegaly with early changes of portal hypertension. And from this, we made an impression of a chronic liver disease with pancytopenia with hypersplenism.
Dr. Seema, would you like to have any other information from the ultrasound here in this patient? She says from this she is making the diagnosis of chronic liver disease.
What about the echo texture? Did you
Increased
say
echo
something
texture.
Huh?
The echo texture was increased.
The splenomegaly with changes of early changes of portal hypertension.
That's all.
And Dopplers you've
Now,
done.
would you not be interested in the portal vein diameter in this patient? Because
Okay,
there
this
is
is
just
already,
splenomegaly. We have normal, liver is not palpable at all.
They're already talking about early changes of.
Right. So portal vein diameter should be actually available in
Yeah.
this patient, and in this child I would say more than 11, 12 would be certainly in favor of portal hypertension. That
hypertension, yeah.
information is not there. Rest of the things are not telling us anything about the chronic liver disease. The liver span is normal, ultrasound, the echo texture is not altered, which might occur actually in acute
No, she's saying the
disease
echo
also.
texture is altered.
No, she's not saying.
Is not altered.
No, it was increased echo texture was present, but
She's not saying.
She just.
So it doesn't matter. Actually, alteration of the echo texture will not give you much information unless you say it's a shrunken
It's
liver.
a shrunken and a
Portal vein
irregular.
diameter is more. Then you would say certainly, or nodules are seen, something like that, or they have done a fibroscan and they show F3 fibrosis. So impression is your chronic liver disease
yes, sir.
based on
Based on that, the liver parenchymal disease with suggestive of increased echo texture
Plus
with splenomegaly.
you can't. Only thing you might say there is splenomegaly, which can occur. There is pancytomeria, there is splenomegaly. Now the next evidence for portal hypertension you have to search is you have to do an upper GI endoscopy. Are there varices or no varices? Or an ultrasonography you showed there are certain collaterals seen. Otherwise, you are not sure whether this is a chronic liver disease or not, so far, by these investigations. Anyway, it's okay, we'll buy that there might be chronic liver disease in this patient. Then, further, what do we do? Now, enzymes are normal, there's no coagulopathy, protein, albumin, everything normal in this patient. What would we do now, further?
Sir, our closest diagnosis will be any metabolic disease because
Yes.
the liver does not show any evidence of cirrhosis, but
Right.
with the splenomegaly and changes of portal hypertension with rickets, with some renal involvement.
Now, suppose you were in a good situation and you would like to know whether there's a liver disease or not. Dr. Seema, what would you do?
I think I would do a fibroscan first.
Yes.
Because of the platelet being low, to go for the liver biopsy, we either have to go in for a TGLB, that's a transjugular liver biopsy, or do a liver.
That is not possible.
That's not.
That has not been done, or even the percutaneous biopsy is not possible with a platelet count of 40,000.
We can give him SDPC and maybe then try and see if we can do it. Otherwise,
In a center like ILBS. Not otherwise.
Transjugular
It's very
liver
difficult.
biopsy is the.
Even we would not do it.
Otherwise, transjugular liver biopsy is what we can do, or fibroscan. Fibroscan is always available. That we can always do.
So you thought that there is a chronic liver disease. Now what is the workup you have done? Let us come quickly because there's an alarm of time.
Our closest
Fast.
diagnosis was Wilson's disease. So we worked up the child for Wilson's disease, and on slit-lamp examination, we found a KF ring with serum ceruloplasmin, which was low, that is 9.79 milligram per deciliter, and 24-hour urinary copper to be high, that is 242 microgram per day.
Interpretation, Doctor Sir. Sir.
You know, this doesn't need any interpretation because it's all abnormal and suggestive of Wilson's disease.
Good.
There's no liver function test that we have seen up till now, have we?
Yeah,
So what is the normal 24-hour urine copper? How much should be normal?
Less than 100.
No, I'm asking her so that it goes to them. So it should be less than 100, and it is high here. Your ceruloplasmin is also low, 9.79. KF ring is positive. Bilateral or one?
Bilateral.
Bilateral. Okay. What is the next investigation? So you are fulfilling the criteria of Wilson's disease by this investigation. What is the next one?
So liver biopsy.
No, liver biopsy we have discussed, not possible. Next. You have done something more. That shows my slide here.
Yes, sir. So MRI brain.
MRI brain.
We will rule out, the child did not have any neurological, symptomatology or signs except that there was a poor scholastic performance. But before starting any treatment, we would like to rule out any brain involvement in this patient. So we had done an MRI brain in this child, and that was typically showing the panda sign. There were symmetrical signal abnormalities in the basal ganglia with pons, midbrain and thalami.
Can you just show panda sign on by your can you show with your pointer? You don't have a pointer. So, Dr. Girish, was it necessary to do MR in this patient? What is your opinion?
No.
No. Seema?
Yes, we won't do it.
We won't do it. Unless there is a doubt from
And
your other parameters.
and if with these parameters, I won't even do a liver biopsy.
Right, that's fine. Yes. Yes, that's right. So what is your final diagnosis? Let's go fast.
So my final diagnosis was osteoarticular Wilson's disease with portal hypertension with a well-compensated liver involvement with hypersplenism causing pancytopenia. The mechanism of Rickets being RTA, which is the more likely possibility, although there was hypoparathyroidism, but it is unlikely in view of low phosphate, and there were normal calcium levels, and there was no evidence of any tetany or any clinical evidence of hypocalcemia in the child.
And secondly, you should also remember, I tried to find out from endocrinology colleagues. They said doing this parath hormone is not easy. Transportation is a major thing in this. It is highly labile hormone, and you have got once only these low levels.
Yes.
So we will, because everything else is not fitting into hypoparathyroidism in this patient. So we will not buy that actually diagnosis. Maybe it is fitting more or less into renal tubular acidosis. And can you just show one slide of literature? Just one slide. Final slide, Rickets and Wilson's disease. Just one slide. Is it available with you? No, you leave it. No, one slide. What is the literature saying on this?
So literature says that
No, go back. There must be a slide.
yes, sir.
Or you
Prevalence.
deleted?
No, sir.
Okay.
So the prevalence is 0.9 to 2.1%.
Yes, just show this. Yes, fine. Prevalence of Laris series 0.9 to 2.1%. And postulated mechanism is renal tubular acidosis, hypoparathyroidism, and hyper is very is a case report. You forget about this. So I think this is the prevalence. So it does occur, but where I don't know whether these patients had actually features of florid picture of liver disease or not. That is not known. And in this patient, nobody, even the best of the best experts in liver, in the first go will not think of Wilson's disease as a cause of rickets. So that's a very rare cause and very interesting. So we must keep it in mind. Wilson's disease can cause resistant rickets and can produce a picture like RTA, which is known. Thank you very much.
Thank you very much.